I'm Sandrine, Kakieu, djossi, and I am honored to be here. I even have a greater honor to be one of the residents of the very first Federal Qualified Health Center Residency Program in Michigan. That is the Oakland Integrated Healthcare Network, also known as Honor Community Health. We provide care to the people of Pontiac, and we facilitate access to care to those populations and the community around. Today, I'm here to speak about a rash known as acquired perforating dermatosis. I know it's dermatology. We will talk about papule, nodule, follicle, and a lot of histology slides. I invite you to stay with me because at the end of this presentation, you will not look at the skin of your diabetic patient with skin lesion the same way again. It is the story of one of our patients that taught us what no textbook can teach us. I hope you have scanned the QR code. I hope you have access to this slide. Next. Why should we even speak about acquired perforating dermatosis? The narrative in the textbook in Google, we say it is a rare skin lesion, but it is estimated that it affects 1 in 10 of dialysis patients with end-stage renal disease on dialysis. It is often mistaken with other common skin lesions that is seen in this group of population. Itching, intense pruritus is the main symptom, and when diagnosis is delayed, care is delayed, and suffering is protracted. What is APD? What is acquired perforating dermatosis? It is the transepidermal elimination of dermal tissue through the epidermis. Those dermal tissue could be connective tissue and could just be necrotic tissue, as in the case of our patient. Connective tissue could be elastic fiber, could be collagen, could be keratin. It is strongly associated with chronic kidney disease and diabetes. The pathophysiology is unknown. However, it is thought that chronic skin injury lead to hyperkeratosis or abnormal keratinization. As I said, pruritus is the main symptom. However, in my patient, non-pruritic, it was non-pruritic. What am I trying to achieve today? At the end of this presentation, I hope you will go home with 3 things. That you will be able to recognize the APD because we will have gone through the clinical feature of this skin disorder. I will have lowered the threshold, I hope, the threshold of going ahead and do a biopsy. And once it is diagnosed, go ahead, consider retinoid as your first line of therapy. By the way, the treatment of ADP, there is no guideline out there for the treatment of ADP. I will go ahead and introduce my patient. On a summer afternoon, on Friday, we had a new patient on our schedule. I thought it would be one of these bread and butter cases. However, when I stepped into that room, everything was different. Sitting in front of me was a gentleman whose demeanor was completely defeated. His body language, his expression was shouting, "I'm here, but I don't hope you are going to help me." He presented with 2-year history of progressive hyperpigmented bump in the skin. He was a type 1 diabetic patient for the last 35 years, and he also had end-stage kidney disease and was on daily peritoneal dialysis for the last 9 years. He also had other comorbidity, heart failure, colon cancer in remission for the last 5 years, hypertension. What did we see? By the way, his lesions were non-pruritic. That is of note. What did we see? This is what we saw. We saw hyperpigmented, keratotic, folliculocentric papule. In simple terms, they were raised first, firm, bump, scattered all over the upper and the lower extremity bilaterally. I will skip here, I will come back here. So we first met him, and we suspected acquired perforating dermatosis. We took the time to advise, to counsel, to tell him about the protracted and recalcitrant nature of this disease. We also discussed the possibility of biopsy and the adjustment of the medication if needed. So at the first visit, we did what many physicians will do for this case. We started steroid and also added a low potency, that is a first generation retinoid. At the third visit, nothing has changed. We decided to go for a biopsy, a chest biopsy at the right knee. And at the fourth visit, our third visit, we have our results. We decided to scale up. We went for a first generation retinoid, that is Aras low, that's the tazarotene, and we decided to go systemic. The aim was to have a synergistic approach to this condition, to attack from within and from without. From within with the systemic steroids, and without, that is outside, with the topical steroid. Generally, everything was stable. There was no more new lesion. And when I met this patient in April, this is what we had. And you can clearly see that those raised lesion left place to a flat patch. Everything that was raised had gone, and we had smooth skin. Left behind was only a hyperemic lesion. I brought this just to give an understanding, to refresh our memory about the structure of the skin. The dermis is down, and it is the material from the dermis that push through the epidermis. Thus the word perforate, the perforate from the dermis to the epidermis. And these are the layer of the epidermis, and we have the stratum corneum, that is the main area where the hyperkeratosis, one of the hallmarks of the disease, occur. Yes, I've mentioned that it accounts 1 in 10 of this population. It is found worldwide. There is no sex or racial predilection. Abnormal keratinization is thought to be the pathogenesis. Pruritus and TED is the most common presentation, but in our patient is non-pruritic. Therefore, you have to have a high level of suspicion to consider acquired perforating dermatosis. It is a clinical histologic diagnosis. That means that you need to combine the clinical feature and the histologic feature to come to your diagnosis. ADP is often missed, as I earlier mentioned, because you have other mimics like prurigo nodularis, folliculitis, calciphylaxis, and the arthroprovine. There are subtle changes that differentiate each of them, and that is why you have the slide. You can go after this presentation and see those subtle changes that I have highlighted there. What has been used in the past for the management of acquired perforating dermatosis? All of this. However, all of them fall short of retinoid, and that is why one of my goals today is that once you are suspected, once you have diagnosed, go for retinoid, because we have seen that it's kidney friendly, it is easy to monitor, and it is safe on this patient. Biology, PDE4 inhibitor, phototherapy, allopurinol, doxycycline, colchicine, systemic steroid, none of them have the disease modifying effect that retinoid has. Some of them have GI toxicity, and some of them are not renally friendly. Some of them are not even easily available. Phototherapy, how many of us have a phototherapy in his office? Therefore, we went for retinoid. We took a synergistic approach. Retinoid, what does it do? It normalizes keratinization at every layer of the epidermis, reduce abnormal follicular plugging, and address the disease at its root mechanism. We use tazarotene and also acetylene. Acetylene was given twice weekly after dialysis. That's the systemic, that's the within. And the without, we use arazole to go topically. Now, I hope I was able to reach these 3 objectives: to equip you to recognize acquired perforating dermatosis in your office. Once you suspect, go ahead and do a biopsy. You have confirmed it, please consider retinoid and you are going to therapy. When I met this patient in April, his mood was elated. He was happy. He was wearing a shirt because the first time I met him, he told me, "Doc, I cannot even wear a shirt." At this time, he insisted to walk me to my car, opened the door, and said, "Summer is coming, and you know what? I'm going to wear a shirt." Next time, yes, this is what happened. Next time, when you are in your office, in diabetic patient, and having dialysis, end-stage renal disease, those papules, those nodules may be acquired perforating dermatosis. Go ahead, biopsy. If you have confirmed clinical histologic diagnosis, don't underestimate the power of retinoid. Your patient life quality depends on it. Thank you. Is it done? Yes. Oh. Yes, those are the references. And you can get ahead and scan again. If you missed the first time, you can assess your knowledge. Let's say, let's see if I did a great job at delivering acquired perforating dermatosis. Okay.
Questions for the presenter? You have 4 minutes left.
How long did it take till you saw improvement in symptoms for this patient?
How long did we take to see the symptoms? Okay. Time was short. January. When he came in January, the lesion was stable. No more new lesion. However, we still have papules, we still have nodules. He lost to follow up. To next visit, he did not come. The office tried to get him, he did not. I decided to call him. He had my number. When he saw the number, he took the phone. And when I asked why he's not coming, he said, "I no longer have those rights. Why should I come to the office?" He said, "You have to come and celebrate with me." That's exactly what happened. You have to come and celebrate. Don't you want me to celebrate? And he said, "Tell me when you want me to come." Therefore, we missed that window exactly when he stopped. He stopped coming. I saw him in April, and then I was also puzzled when I saw everything was gone. And that is why you may notice that the title on your paper is different from what we have, because it was still, it just happened. Yes. Any other questions? It was a very exciting journey, especially seeing the impact, the emotional impact he had on the patient. And that is what we do best. We don't just treat the disease, we treat the patient, the entire patient, not just the disease.